complications. He has an excellent talk on this. Anthony?
Mark, thank you very much. I'd like to thank the organizing committee for the invitation. This is my first time to Kiowa, and it's quite impressive, the meeting as well as the venue. It's always a mixed blessing to talk about complications of procedures. I think it's human tendency to want to hear about people's failures a little bit more than people's successes. So it's kind of appropriate to put these at the end of the session. I will tell you what you will see today is a collective experience, a personal experience over 450 thoracic endovascular procedures that I've performed in the past about 7 or 8 years. And if you can think of a complication, I've committed it. These are my disclosures. I want to start off with this concept, and I think this should be reminded over and over again. This is not a story about a device, it's not a story about an institution, it's not a story about a person or a technique. It's an equal opportunity hazard that goes across the board, across all operators. And as Mark said, if you do enough of it, you're going to encounter one or more of these. This is a fairly complicated laundry list of complications. I don't claim this to be complete. I think it's fairly comprehensive, and as I said before, I've committed each and every one of them. For the sake of time, I can't possibly discuss each of these individual line items, but I'm going to concentrate on just a few of the key ones, and some of these have been already covered by the previous speakers. One of the most important class of complications in thoracic endograft therapy is neurologic, and starting from the top is stroke. If you look at the literature, the rate of stroke varies quite widely, anywhere from 4 to 10%. We did our own institutional review down at University of Florida recently of 400 consecutive thoracic endograft repairs. Our stroke rate is just at 6%, which is slightly right in the middle of this range. It's been associated in some publications with more proximal coverage, namely zone 0 and 2. Mechanisms can involve both ischemic as embolic issues, and obviously we all have to obey compulsive catheter and guide wire hygiene, minimizing any kind of manipulation, and heparinize. And these are some real-life head CT scans and MRIs from my own patients who unfortunately suffer these complications. One of the things I think, as John Economidis mentioned earlier, that I don't think most operators had a true appreciation of the importance of the posterior circulation vis-a-vis the left subclavian artery coverage. I think we have a lot better appreciation in 2010 compared to 2000 when I started doing this. And the left vertebral artery, as we would have it, meaning human beings, is dominant actually in about 2/3 of the human population. There are a couple of so-called PIC, posterior inferior cerebellar artery anatomies or syndromes that I recognize. In about 1 to 2% of the human population, there is so-called complete right vertebral disjunction. That means the left vertebral artery is the sole or the primary posterior circulation or source of perfusion. And this is illustrated in this diagram right here. Another interesting finding is about 3 to 4% of the individuals have what's called atresia or hypoplasia of the right vertebral artery, illustrated here, where there is an actual physical arterial connection to the common basilar trunk, but it is functionally not very contributory. Just in case some of you may not believe me, these are some actual CT reconstructions of such anatomies. This is a so-called normal, well, I shouldn't say normal, or the co-dominant system you could see on the left and the right joining the common basilar trunk. This is an example of right vertebral atresia or hypoplasia. This is a right dominant or the mirror image of that. This is complete atresia of the right vertebral artery, where the left vertebral artery is very dominant, and the mirror image on the other side. Left subclavian artery revascularization has therefore become a little bit of a hot topic, and the opinions are quite divided in terms of selective revascularization versus routine revascularization. I should disclose that I am one of the former or believer of selective revascularization, and I think in 2010 it is fairly well accepted that if you have a case of dominant left vertebral artery, as illustrated in the previous slides, you should certainly revascularize it. If you have a patent lima graft to the LAD, if you will, as a coronary bypass, you should certainly revascularize that. And some of the relative indications you could include a left-handed patient an aberrant arch origin of the left vertebral artery, which is something that people don't often think about, and this is an example right here in the lower hand corner where instead of a classic 3-vessel arch, you have a 4-vessel arch. And the reason why we have to think about this is, believe it or not, the left vertebral artery is the dominant collateral circulation to the left arm. As some of the other speakers mentioned, a functional left upper extremity AV shunt is also a relative indication, and the very, very rare case of a left-sided base AXFEM bypass. Switching gears to the second major neurologic complication is spinal cord ischemia. Again, you've heard this from the other speakers. The mechanism and scientific evidence behind the incidence as well as the rate is very poorly established, secondary to a multitude of different practice patterns and pathologies being treated by this therapy. But I think most people will agree that these are some of the well-recognized kind of anecdotal risk factors, including length of aortic coverage, prior abdominal aortic surgery, pelvic occlusive disease, subclavian artery coverage. Having said that, the data behind left subclavian artery coverage is extremely weak. In point of fact, the one paper that was previously shown by the other speaker is probably the only evidence to support it. Most of the evidence is very mixed to negative. Perioperative hypotension has also been mentioned, and renal failure has also been cited. At University of Florida, we have a spinal drain management protocol. We are one of those institutions that routinely place spinal drainage in select cases based on evidence provided by our own institution. We did a multivariate analysis specifically looking at these various factors covering over 250 consecutive cases. And what basically that panned out is coverages. The length of coverage is very important, such that when we cover more than 15 centimeters of thoracic aorta, or we cover within 5 centimeters in proximity to the celiac artery, we routinely drain these people. Our drainage protocol is we try to limit the drainage to less than 15 milliliters an hour, or less than 350 milliliters for over a 24-hour period, because of some anecdotal evidence that over-drainage may be associated with an increased risk of subdural hematomas. When we drain these people prophylactically, 24-hour drainage followed by a 12-hour test clamp and removal. When we therapeutically drain these people such that those individuals who, for whatever reasons, we could not place a spinal drain preoperatively, but they had signs of spinal cord ischemia and we had to put them as a therapeutic measure, we routinely drain them for 72 hours, 24-hour test clamp, and we remove them. We typically want to take the drainage catheter out no more than 5 days, simply because, again, some anecdotal evidence of increased spinal infections.